Okay, it looks like we've got everyone settled in. Welcome, everyone. We are pleased to welcome you to our Realizing Healthier Pregnancies Research Cluster. Thank you for joining us today. My name is Erin Shobloom, and I'm a PhD student in epidemiology and a grad research assistant under WCHRI member and presenter today, Dr. Stephanie Montesanti at the School of Public Health at the University of Alberta. I'm pleased to serve as a session moderator for our presentations today. And on behalf of WCHRI, thank you for taking the time to attend this session. Okay, I'm just going to share my slides here. Okay, I want to start this in a good way by acknowledging that this conversation is taking place on Treaty 6 territory, the traditional lands of the Nehiyawak, Dene, Nakota Sioux, Saulteaux, and Blackfoot nations, and the homeland of the Métis. Alongside this land acknowledgement, I want to situate myself and share my relationship to the land and to Indigenous peoples. I'm a mother, partner, daughter, and granddaughter, friend, and colleague. I'm a settler of European descent, and I grew up in Treaty 8 territory in Fort St. John, British Columbia. Over the past 15 years, I've worked within Indigenous-led organizations, mostly in Manitoba. I'm still a baby in Alberta, where my responsibility has been as a helper in health promotion and research. My relationships have been primarily, and I already mentioned this, in Manitoba, as I'm new to Alberta, but I'm committed to working on building meaningful relationships in Alberta and connecting with the land here. This leads me to the next slide, which I hope underscores why we acknowledge the land and why we ground ourselves in our work and our relationships to each other. This is a quote from Dr. Tayaki Alfred, where he's talking about how colonization is a process of disconnection. It disconnects us from our responsibility to ourselves and our values, our responsibility to the communities that we belong to, and responsibilities to take care of and show up for the communities that we don't belong to. So by situating ourselves in our relationship to the land and our responsibilities and relationships to each other, and committing to honor our responsibilities and engage in health research in a good way, we are doing a small act of decolonization. And I just want to next thank WCHRI's funders, the Stollery Children's Hospital Foundation and Alberta Women's Health Foundation, for making this research cluster possible. Okay.
Thank you, Erin, for opening up our meeting in a good way. Am I able to share my screen now?
Yes, please. I have one more comment. Sorry, I was just switching between screens. So if you want to join the cluster, please reach out to Michelle to nominate your collaborators or networks, or join yourself. Michelle will stay in the session to answer any questions you may have about participating in the research cluster afterwards. The session will be recorded and posted to the WCHRI website. WCHRI will send out the link to the recording. Please allow 24 hours to access the session recording. And we're looking forward to sharing our research with you and encourage questions after each presentation. So on to the main. Introduce to you Dr. Stephanie Montesanti and Sheena Bradley. Stephanie Montesanti is an associate professor and Canada Research Chair in Health System Integration in the School of Public Health at the University of Alberta. Dr. Montesanti's research program is dedicated to advancing actions that reorient health systems toward health equity and strengthen connections between health systems and communities. Her research applies systems science, implementation science, and a person-centered lens to the design of integrated healthcare improvement strategies in the areas of Indigenous primary healthcare and women's health. She's the academic lead for the Learning Health System team at the Alberta Strategy for Patient-Oriented Research, the SPORE Support Unit, and Women's Health Research Ambassador for the Alberta Women's Health Foundation. And then Sheena Bradley is Cree-Métis and a member of the McMurray Métis Local 1935. She is a traditional clinical herbalist, full spectrum birth worker, and lactation counselor. As the founding executive director of Ifwipaska Collective, Sheena also serves as a project lead for the Aunties Within Reach program, offering personalized one-on-one care to clients. Sheena Bradley advocates for culturally inclusive care for Indigenous families in the regional municipality of Wood Buffalo and helps to reclaim traditional birth practices. Okay, Stephanie and Sheena, would you kindly take the floor?
Thank you so much, Erin, for the kind introductions. Thank you to WCHRI for inviting Sheena and I here today to deliver this presentation. I'm really delighted to be joining Sheena, who is both a community partner and friend, and hopefully a lifelong partner in crime, and supporting communities to really address and close the gap in perinatal health disparities. I want to also acknowledge that I'm a learner in this work. I've learned so much from the Aunties Within Reach team in Wood Buffalo, and have been inspired by the amazing work that they've been doing. So it's always a pleasure to be sharing about the program with other colleagues and friends and peers. So thank you to those who've joined. Oh, where are we going? Okay, I'm going to hand it over to Sheena, who's going to provide some reflections on acknowledging land and her connection to the work up in Wood Buffalo. Over to you, Sheena.
Thank you so much, Stephanie and Erin, for that really good opening. Thanks again. So obviously we're on a little bit different territory, as a lot of you are located down in Edmonton area. So we just want to acknowledge the land that we work on and that we live on and that we're from in the municipality of Wood Buffalo. So our region is very large and very biodiverse. Situated on Northern Treaty 8 territory in Alberta. So we just want to acknowledge and share the land that we work on and our deep roots that are connected to this land as well. And a lot of our work is in relation to the land as Indigenous people. So wanting to honor where we're from and the land and communities that we get to work on daily, or in daily, sorry.
Thank you, Sheena. So we want to just provide a brief outline of our presentation today. We are hoping to have some time for engagement, some interaction. So we've built in some questions along the way. But what our plan is for our presentation is we want to begin with some introductions. So in a moment, Sheena and I will share a little bit about who we are and what drew us to this work. We will begin with some background or context, specifically looking at community integrated primary healthcare models for Indigenous populations, and the Aunties Within Reach program, which you'll learn a lot more about momentarily, is a model of community integrated care. Well, Sheena will introduce the Aunties Within Reach program and share some highlights about the program, what the program offers, its reach in the region. I'll highlight some aspects about the research. So the care lab situated within the School of Public Health has partnered with the Ikapasqua Collective, which is led by Sheena Bradley and Maddie Amiot, who co-founded the collective. And it's through that partnership that has facilitated our community academic research work to support the Aunties Within Reach program. So I'll highlight a bit about the research that's underway and how we are drawing on implementation science frameworks and learning. And as I mentioned, hopefully have some good discussion. We also hope to highlight in our talk who we are, how we got started, how far we've come. I know we're proud with respects to how far we've come, and it's been a long journey over the past few years, and to highlight where we're going. So Sheena, why don't I have you start first, introducing yourself?
Sounds good. So as everyone mentioned, my name is Sheena Bradley. I am Cree and Métis from the region. My granny Boucher was born north of Fort McMurray on Lake Athabasca. Local 1935, as well as the Métis Nation of Alberta. I am a mom of two. I have older teenagers, 16 and 18. So now I'm a very dedicated auntie, also a clinical herbalist and full spectrum birth worker. So that's my community roles and the work that I do. And then as mentioned, I am one of the founding executive directors of Ikapasqua Collective, which is our nonprofit in which we've partnered with the Care Lab for our program Aunties Within Reach.
Thanks, Sheena. And hi, everyone. I'm Stephanie Montesanti. I'm a mom. I have a 4-year-old who keeps me very active and busy. I'm also an auntie to many nieces and nephews. I'm a daughter. I'm a sister. I'm the youngest of three girls. So I have 2 older bossy sisters, which I don't mind, but sometimes I do. And I'm a non-Indigenous health policy and systems researcher with deep passions in community-based research and working with Indigenous communities. Most of my background actually started in women and children's health. So I worked globally in Ethiopia for a nonprofit called Women's Mary Joy Aid through Development, which was a women's empowerment nonprofit. And that nonprofit worked primarily in the area of HIV/AIDS, and then moved to Cambodia and worked in rural Cambodia in the area of women's health and pregnancy in particular. So women's health has been a lifelong passion of mine, and have come full circle in more recent years, coming back to that work in Indigenous communities. And yeah, I'm joining you from my office here at the University of Alberta. Right. So we wanted to begin with some background information just to set the conversation for our presentation. We wanted to begin by talking about complexities in Indigenous patients' access to health services, and to highlight some relevant information about the health system context. So within healthcare settings, Indigenous peoples are frequently regarded as patients with complex health needs. And I think that lens and rhetoric can be problematic in how we deliver services, health services and care for Indigenous peoples. Patient complexity is deemed to arise from a combination of personal, social, cultural, and environmental factors that influence health status, but also complicate their access to healthcare. This is something that our team on the ground, our Aunties Within Reach team, navigates on a day-to-day basis in terms of providing social, cultural supports, support with system navigation, navigating health and social systems that are complex by nature, in terms of complexity in the sense of the types of services that are offered, complexities in terms of policies and procedures that often the team needs to navigate in order to get the services to their clients, but also recognizing the importance of the social determinants of health. Where you live plays a role in shaping healthcare experiences and health outcomes. Connection to social networks, your relationships with family and friends plays an important role. And a big part of our research program is looking at healthy family systems and how colonization has disrupted family systems. And acknowledging that Indigenous peoples have distinct contextual factors that are arising from historic and ongoing colonialism that undermine their health. In response to the inadequacies offered by Western or mainstream health services, we've seen innovations in Indigenous models of care emerge. And these are models of care that are community derived and led by Indigenous peoples. They are meeting the needs of Indigenous communities. They're responsive and filling important gaps within health service access. So, it's also a response from how Indigenous peoples have been harmed in the healthcare system and how they felt excluded from those systems. There's a growing body of evidence that has shown that Indigenous-led health services programs or interventions are more likely than Western services to improve the health of Indigenous communities, and are also more likely to be sustainable. Indigenous-led health services are also underpinned by the values and principles of the communities they serve. And more importantly, this is about strengthening a local Indigenous health workforce. It's about honoring, acknowledging, respecting, and valuing important community roles that Sheena mentioned earlier, and uplifting those roles. I will touch on in a little bit about some of the history around payment and funding for traditional or roles such as birth workers and midwifery, and how that backdrop in terms of the policies, those policies can create barriers or challenges in delivering reproductive health services for Indigenous communities. But it's that policy context that our local team is navigating. Our team within the Care Lab has conducted a global systematic review to look at key characteristics of Indigenous models of care. So what are those key characteristics of those models that make them successful, and what has influenced their implementation in a range of different community or geographic settings? We started off doing this review, we're now turning it into a living synthesis. A living synthesis is essentially a way building in ongoing or updating our search strategy so that we can continue to learn about Indigenous models of care across the globe. So every few months, we're updating our search strategy to identify new literature, new evidence on Indigenous models of care to continue to build on our understanding of what goes into these models in terms of those characteristics, and what do we know, what can we learn about their outcomes. So what I've outlined here are a few key characteristics that we see in Indigenous models. Importance of culture and embedding cultural values, traditional healing practices into services, programs, or interventions. A second characteristic is focused on community engagement and really centering the voices, perspectives, and values of the communities that are being served. Community engagement is not static, but really needs to be ongoing. The importance of integrated and coordinated care. So ensuring patients receive a continuum of care that is integrated with other healthcare providers, and I should say other health and social care providers and across different systems. That it's patient and family centered, providing support and care for individuals and the whole family. And holistic, supporting the mental, emotional, physical, and spiritual needs of clients and engaging with the social determinants of health. So these characteristics might not seem new to many in the room today, but they are important in really grounding how we design Indigenous models of care and deliver them. But more importantly, I think there's so much that we learn from these characteristics in designing and implementing Indigenous-led programs. With respect to community engagement, we learn about how communities want to be engaged. We learn about how that community engagement often encourages us to reflect on what's working or what's not working in our program, or what we can change and how we can do better in terms of expanding reach of our services. I also wanted to make a note about community-enabled health, because really this work is about community-enabled health. It's about empowering local communities to design, deliver, and support health services, rather than relying solely on Western healthcare systems. It's about trust and relationships, and trust and relationships strengthen collaborations. And collaborations fueled by inclusive and diverse perspectives promote co-design, co-implementation, and co-learning, enriching our collective knowledge and understanding. And all of this results in more sustainable programs. And here I just wanted to highlight a few key conditions for community-led approaches. It's about a shared community concern. It's about having a sense of responsibility and a desire to act. There's work in scholarship that is trying to do a better job of conceptualizing what we mean by integrated community care. And you heard me mention that our Aunties Within Reach program, which Sheena will share momentarily, is an example of a community integrated model of care. And so just wanted to highlight or include a slide here to articulate what do we mean by community integrated care. So in 2016, the WHO mentioned that there was a lack of a conceptual definition for the concept of integration in the field of health and social care due to its polymorphic nature. So when we think about the realities and perspectives that underlie this concept, they are likely to be shaped much more by the views and expectations of different health systems and their actors. And so this has been very much true for our work in Wood Buffalo, where we're exploring, well, what does integration mean for us? And sometimes working in integrated ways can be complicated, but also rewarding, and maybe at times necessary. It's also about interdisciplinary. It's about bringing key providers working across these systems, across health and social care together. And it's about those relationships. When we think about integrated care, it's also about the local area. And when we look at the local area, part of that is geographically in terms of where those services are being delivered. That brings for us a number of questions or considerations rather around remoteness of some of the communities that the Aunties Within Reach program serves. Also about the meaning that individuals attach to the place in which they live. Places where they live, community settings are very much about places where there's cultural and social connections. Places where families are grown and reside together. So that understanding is really important with respect to that local area and the context. And temporality really is about how people's connection to the space. It's also about relationships and time. So as community-based care providers, and I know Sheena will touch on this, is much of the work is really about time, the time that is needed to build relationships and trust. Sometimes a visit out into the community is not, that time doesn't necessarily lead to providing cultural supports or clinical care, but sometimes it's a place to visit with clients, build relationship, hear their stories. So time is really important when we think about temporality. The healthcare system traditionally can be seen as primary care, which is the first point of contact for many individuals accessing the health system. Secondary, tertiary care. These are both systems our local Aunties Within Reach team navigate on a regular basis. We often talk about spatial proximity in terms of geographical access to services and how are we bridging that gap in terms of accessing those services. And relational proximity, which is so important, I think, in community integrated care, but can also be a challenge because proximity sometimes can be a barrier or a hindrance in not being able to be in the community all the time. And so I think that's something that the team is often, confronting and navigating on a regular basis in terms of how to be more present or allow for that time and space to be more present in the communities. But some of the key takeaways that I wanted to highlight is that community integrated care is really about empowering people, families, and communities. It's about strengthening care and enabling environments. And it's about reorienting health and social systems towards health equity. So for those in Alberta, and I didn't take a good look, I assume probably most of everyone here is from Alberta. So there's a large primary healthcare reform agenda underway in our province, which is known as the Modernizing Alberta's Primary Healthcare Strategy. This visual here on this slide is from a report that was produced by the Indigenous Primary Healthcare Panel. The report was titled Honoring Our Roots, Growing Together Towards a Culturally Safe, Holistic Primary Healthcare System for Indigenous Peoples. And while the discourse in the report surrounding this framework didn't really identify this as a model of integrated care, it really spoke to me as a of integrated service delivery. We have Indigenous patients at the center, but we think about integration, not just in terms of integrating across services, systems, and professions, but it's also about integrating different knowledge systems. It's about integrating our measurement systems. It's about building capacity within the health and social workforce to do this work. It's about including Indigenous peoples as partners. It's about collaboration and coordination. And all of this can be extremely complicated, but when done well, necessary in terms of sustaining health service delivery and meeting the needs of Indigenous communities and peoples. And as I've been alluding to, this doesn't come without some challenges. So I'm going to hand it over to Sheena to talk about what this has meant for her as a care provider on the ground.
Thanks, Stephanie. So as Stephanie was alluding to, like our proximity within our communities and the remoteness of our communities, we do have to do a lot of travel. So, and that is in one of our slides kind of showing you where we go and the communities that we serve. But a big thing of this is our lots of travel time. So we're flying out to community, we're driving an hour and a half to another community, and then trying to fill all the gaps that we can. So there's definitely been a really high burnout rate amongst like implementation teams. And really that's a number of things where there's poor or inadequate policy decisions. So a lot of the times we're having to navigate policy. We're having to navigate different things that have played in decision making for healthcare, for accessing healthcare within our region. Also, our communities have suffered from a lot of crisis and emergencies. So even within the past few years of operating Aunties Within Reach, we've had not only COVID, but we've had flood, we've had natural disaster, we've had also a community state of, like a local state of emergency with mental health and addictions in 5 of our First Nations. So really crisis and emergencies in this region specifically is nothing new, but having to navigate that while also trying to incorporate traditional models of care and having a higher rate of prenatal health care access has been very challenging on our providers. And then also partnership fatigue. So one thing that we've really tried to do is connect with other organizations within the region as well to see how they can support and fill in gaps. But it's hard when you are Indigenous healthcare providers or Indigenous traditional practitioners and feeling quite alone in this work and trying to bridge all the gaps, trying to fill all the pieces that you possibly can. And we have 12 First Nations and Métis communities. So we can become quite stretched thin. and that goes into the next point of the high needs and high demands. So when we first started our program, there was 3 birth workers. And we've since been able to grow our team strategically and intentionally with proper healthcare providers that we can really bridge gaps. But with travel and with client needs, there's been a very big strain on capacity. So that's definitely played into it. And I think, one thing too is also our own experiences as Indigenous people and having to help families through certain situations where we have also had to face these situations ourselves. So that does add a whole other level of complexity to this level of care of navigating our own triggers, navigating our own healing, and how we show up as providers. And as we mentioned, the geographical remoteness of some of our communities, which we'll show you momentarily, but it is a lot of travel. 2 of our members yesterday flew up to Fort Chip for the day. We do like to go overnight every once in a while because we have a long list of elders that want to sit and visit. So we make it a point to try to go up at least once a month to go visit and see clients and do programming. And then we have a large number of clients that are we service in urban Fort McMurray, and then we also travel to another community, Janvier, which is about an hour-and-a-half drive each way. So travel is a big part of what we do, and travel is one thing that's really poorly funded too. Whether it's through midwifery or through our nurse practitioner program, it's just not funded well. So that is another layer of constraint for funding is that travel. And then again, health systems and political changes. So one thing that we've been really trying to push forward is, we have this team of healthcare providers and traditional practitioners that can go to communities to really limit medical travel. And it's really hard to change people's way of learning of that's a possibility because we're so used to we send parents in at 36 weeks. That's just what we do. That's where the funding is. That's what we have funding for. So let's just continue to go down that path. But we're really trying to change the narrative on that. So again, working with health systems that see a certain way and trying to change their views on some things can be quite difficult. So while the work is really community focused and really rewarding at times, it can be quite exhaustive.
Thank you, Sheena, for sharing those perspectives and thoughts from your own experience. So we're actually now, I think with the moment everyone's been waiting for, is to introduce you to Aunties Within Reach. So we have a bit of a video montage here that's put together by our community engagement and project assistant, Kaylin Duke. And while the video is playing, Sheena, if you wanted to just start to talk a little bit about AWR.
Absolutely. So I'll first start out by acknowledging our team, who we do have on the call right now. They probably, I don't know if they can use their video or not, but we have our team members here. So a lot of what we do, and you can see in the pictures, is really facilitating community programming, and really being those good aunties that just support families in the way that they need to. A lot of our programming is done on the land. One of our programs is blueberry picking and baby wearing. So having families go out on the land and teaching them blueberry teachings with elders and other community members, but also teaching them baby wearing. And again, reinstilling that connection to land being so important of bringing babies into the world and that connection to land for us. The picture of the baby in the moss bag that is shown quite a bit. That was our first little AWR baby when we first finished our training. So it's a fun program, and we've grown our team really intentionally. So we're able to offer more capacity. And in that picture too, you'll see Maddie we now have a mobile ultrasound machine. So we can now do point of care ultrasounds in community, which is just again, like mitigating that need for medical travel and having one less need for families to come into town for a point of care ultrasound, where we can bring it up with us and we can do it right there. So that's kind of a little bit of our program. I don't know if you want to add anything more, Stephanie.
Thanks, Sheena. Yeah, we do have a couple of slides that kind of get more into, oh, hold on, how do I stop this now? Right. Okay. Yeah, we do have a couple of slides just to build on what you've shared, Sheena, and you've touched on most of this already, but just some of the particulars. So we do see Aunties Within Reach as a model of primary healthcare delivery. It employs a multi-service model that reflects a wraparound approach to care, as Sheena described. It's intentionally geared to removing barriers to accessing reproductive health services. It includes a dedicated support line, referrals, providing access to information, resources, and advocacy for clients, in-home visitations, cultural mentorship during pregnancy and postpartum. Sheena talked about some of the community education that's done each month in the communities, and which usually involve like workshops, right? Sheena, did you want to highlight a little bit more? You talked a little bit about it, but I wasn't sure if you wanted to highlight a little bit more some of the community engagement that we've been doing.
So some of our program, like all of our program, is really guided by each nation, because they each have vastly different needs. So we do offer programming right now, like workshop programming in Fort Chip. And with that, we've partnered with Athabasca Tribal Council with their Roots and Berries program to really just support families. So we really take the guidance of the community members of what they're wanting and needing to learn, and able to help them with different things in their pregnancy or maybe postpartum. Yesterday they did some swing teachings. We've done rattle making. We've also done like moontime teachings with the youth there. So it's really guided by the community. And for instance, in Janvier, we've done a lot of prenatal education and postpartum education. Next week, our plan is to do a potty training session in Janvier, again, guided by the community. So they're seeing needs. We have public health that we work with closely in community too, and they're seeing a need of education in certain things. So we come together and try to collaborate on a cultural approach to that. So having our aunties go out and support with potty training techniques. I know they're also planning like a lice educational workshop. So really guided by community and the elders that we work with in community. So it can vary month to month, but we have kind of a list of things that we are able to support in and provide education.
Great, thanks, Sheena. I just wanted to highlight as well, like the importance, a key component of the program is bringing together both clinical midwifery knowledge and Indigenous cultural knowledge. So up until recently, there was just one Indigenous midwife serving the communities in the region. And recently, the AWR team, or Iga Pascua Collective, was able to recruit another Indigenous midwife. And so I think that's been so important just in terms of capacity and supporting clients. And so that's what's really, I think, in my opinion, so novel about the program is bringing in the clinical aspects of the care, and that midwifery care is supported by an Indigenous nurse practitioner who on the team as well, and with Sheena and the other auntie navigators really providing the Indigenous cultural knowledge. Sheena, you talked about how you're, as a traditional herbalist, that's such an important piece too in terms of the services that are also being offered, and wanted to know if you wanted to share a little bit more about that.
For sure. So we do, so I do offer programming in community. So we've done a few where they can, like, people will teach on like how to make your own kind of products for at home. So your own traditional medicine pharmacy, we like to call it, or your own traditional medicine like first aid kit. So that's one way that we try to incorporate traditional medicines. But every client that we intake into the program has access to a traditional practitioner. So they have access to traditional medicines, and we do, like myself as a clinical herbalist, does a full intake with that person to really go over their medical history, kind of what their needs are, and we come up with a variety of different treatments for them. So whether that's a tea, tinctures, topical applications, herbal baths sometimes, and even smudge. So really looking at the person as a whole, and using my clinical expertise to understand even like what medications they're on, contraindications in herbal medicine or traditional medicines, which is really important. But being able to support them throughout their pregnancy and postpartum with traditional medicines, I think has been really valuable, because not only are they accessing our Indigenous midwives and our nurse practitioner as medical care providers, but they're also receiving, traditional teachings from our aunties, and also receiving traditional medicines in a way that is accessible to them. It's also been interesting trying to figure out ways to fund that as well into our program, where it's not traditional medicines funding isn't in programs very often. So trying to navigate that has been interesting as well. But we're often we're in our community roles, and we're gifted just as much as we gift. And I think that's one thing that's really important in my herbal practice too, is medicines show up when they're supposed to show up, and you gift medicines when you need to. And we have this with our elders as well. Our elders come to us and will gift us certain medicines that maybe we can't find, but we make sure that we have medicines for them that we can also share. So it is really this community supporting each other with traditional medicines that we're needing. So it's a really nice implementation to our program that isn't seen a whole lot.
That's great. Thank you so much, Sheena. Okay. And for those who may not be familiar or as familiar with the Wood Buffalo region, just wanted to highlight that, so it is a northern rural remote region in our province. There are 6 First Nation communities, 6 Métis communities in the region, and the Aunties Within Reach program serves the entire region. With the 2 most remote communities being Fort Chipewyan, which is a fly-in hamlet, and Janvier, which includes Fort Chipewyan Prairie First Nation, being the 2 most remote communities. The AWR team are going out on rotation about every 2 weeks, right, Sheena? And seeing clients there. So we'll have the midwives go out and do checks for mom during pregnancy or postpartum support. Bringing a nurse practitioner on the team has been really important in terms of continuity of care and support, as midwifery is only funded up to 6 weeks after birth. So at that point, clients under, working with Maddie, for instance, who's one of the midwives, there'll be a warm handoff to Lisa, who's the nurse practitioner, to continue to provide that support. So yeah, that's just a little bit about the region, which is absolutely beautiful. You can see the landscape here. Fall is one of my most favorite times, being up in the region, just seeing all of the beautiful colors. And I know it's probably a favorite time of the year for you too, Sheena, with lots of opportunities for medicine picking. Okay, so why did we develop a community integrated model of care? Maybe just start off and have Sheena jump in as well. But it started with aspiration. So Sheena and Maddie were one of the first trained Indigenous birth workers in the region, and That's a part of their lifelong vision is in terms of training more Indigenous birth workers in the region. But being the first trained Indigenous birth workers had that aspiration to bring that back to their region and give back to their communities. There was an identified need and critical gap. So you've heard us talk about limited availability of reproductive maternity services in remote communities, including traditional and cultural supports. There's also the community and healthcare context. Sheena talked about multiple crises in the communities, barriers to accessing reproductive health services in general, as well as healthcare harms that many Indigenous peoples experienced and continue to experience in the healthcare system. And this desire or intent, perhaps an accountability in redressing colonial legacies. She had also talked about some of the historical policy legacies or decisions that really impact the reproductive rights of Indigenous mothers. One policy in particular is Health Canada's forced pregnancy evacuation policy that requires Indigenous women or all women living in remote communities to evacuate their home community at 36 weeks pregnancy to the nearest urban center. So for the region of Wood Buffalo, that's Fort McMurray. Sometimes, depending on health system constraints or if there are complications, the mom might be evacuated to Edmonton. So they are removed from their social support systems with very little access to any funding to even bring their partners with them or if they have any other dependents. And this is a policy that the AWR team has to navigate on a constant basis, not just in terms of the impacts, but just, yeah, maybe I'll have Sheena, I'll have you share a little bit more about how the AWR team interfaces with this policy and perhaps other health policies and the healthcare system context broadly.
So I think one thing we know is that due to like the remoteness of some of our communities, bringing birth back to community is ideal. However, kind of what our motto is, or what we say is, we want to bring birth back to community as much as possible. So realizing that maybe we won't have births, within the next few years within our communities, but how much can we possibly bring back to community to really empower communities to hold that in their own home communities, where families don't have to travel. And if you've ever been to Fort Chip or to a small community, you're in a 9-passenger small plane. It's not a fun airplane ride. And then, you're looking at the economic factors that's playing into the community as well, where your partner's now leaving work, your kids are out of school because you need to bring your kids because there's no childcare available in the community because you're in town for 4 to 6 weeks. So it's not just a short visit, it's very lengthy. And given the crisis in our communities of mental health and addictions as well, and now we're placing people into an urban center where generally their hotel that they stay at is not a great location. The casino is across the road. There's triggers all around. So it can be really difficult, where when we're providing care in community prenatally, we are building those relationships with people that are coming into town to deliver, to give birth. So we're making sure that there is that continuing care from community to urban Fort McMurray and then postpartum back into community. So ensuring that they are seeing one healthcare provider that's culturally sensitive, trauma informed. We have our Indigenous midwives and our nurse practitioner, but also incorporating birth work into that, and making sure that they have an auntie here to greet them when they're coming into town to stay in the hotel. And that when we're back in community, when they're postpartum, we're doing home visits in community. We're making sure that they have meals and they have food and they have appropriate housing. It's trying to work within that policy, but to kind of bring things back as much as we possibly can. So it is difficult. And I think we've had some really good relationships with healthcare providers as well. I think we get quite a few calls from the hospital. We've developed a good relationship with Matt Child, where they'll actually call us if there is an Indigenous mom that they think that they need some support. They'll actually call us, and in a lot of situations, they'll actually call us before they call CFS or Child and Family Services, which to us we've been able to kind of mitigate a lot of calls to Child and Family Services, and to make sure that those families are well supported when they go back to community. And that's, to us, the most important part, is that those families are well supported.
Thanks, Sheena. Sorry, I didn't realize I was on mute. This is also about reproductive justice. It's about the right to manage reproductive capacity. It's about the right to access, and it's about the right to parenting. And Sheena, I thought I'd hand it over to you to also highlight what this means to you in the context of your work.
For sure. And I'm really glad that we, kind of put this into our presentation as well, because everybody has a right to reproductive health care, whatever that looks like for them. And, just kind of going back a little bit too on access to healthcare, we have community health centers within each nation, within each rural community. But we have, with our relationship building with our families, we have come to know that those are not safe places for people sometimes to access healthcare, and in a safe way, where it is private, they can access it without judgment. And one example of this is termination support or abortion support. In our region, pregnancy termination is extremely difficult to access, and it shouldn't be. We really want to mitigate that and make sure that people have options and people know what their options are, and that people can have respectful and judgment-free access to that, because that is their right. And exactly that, the right to access. So we want to make sure that we are having a safe space for them, because they have the right to access maternal health without discrimination, whether it's in their community or in urban Fort McMurray in the hospital there. And then a right to parenting. As I had mentioned, a lot of what we do is working with Child and Family Services, or working to support families to ensure that they are well supported, to kind of keep Child and Family Services at bay. And we'll actually be brought into parenting plans as a support person for those families. We have really good relationships with our tribal council CFS, who's really entrusted us to ensure that families are supported in the right way, because a lot of our CFS calls, especially right from the hospital, from healthcare providers, is the simple fact that these families aren't supported, that they don't have a natural support system, they don't have a healthy support system, they don't know how to bath baby, they weren't taught certain things. So how can we really empower these families to be the best parents that they can, and support them along their journey? We don't cut off at a certain age, or when we've reached certain milestones. We're aunties, and we will always be aunties to these families, and really work with them to walk alongside them in their parenting journey.
Thank you, Sheena. So when I was putting this slide together, I had gone online and wanted to pull some articles, news articles, to just bring home the point of that there is a social movement, a global social movement to bring birth back to community, or back to the land. But what really surprised me when I was going through the web and trying to pull out articles is that there wasn't very much. And so some of these headings might seem, shocking, and I'll highlight some of what I have here. But I guess I had, just knowing that there's been so much advocacy and seeing a lot of advocacy within our team and our group on these issues, I guess I had hoped to see more advocacy, like more of this being brought to the forefront, more of this being brought into news, being, shining a light on the fact that what the impacts are around forced evacuation for pregnant women, more about the state of midwifery, Indigenous midwifery care in the community. And we're having these conversations. I've been, had the opportunity to listen in on these conversations and engage with many of these conversations, much like Sheena. So I guess I had hoped to see more highlighted in mainstream media or news. And all this is to say, is to put this as a plug, is to say, we need to get out there. We need to be shouting at the top of our lungs. We need to be advocating. This is not okay. We need to be uplifting and acknowledging and respecting the strengths, the gifts, the wisdom and knowledge in the communities. I know Jenny Flett is not the only Indigenous midwife in the region. There are others. It's the one that just comes to top of my mind. But Jenny Flett was a Métis midwife in Fort Chip and gave birth to 400 babies during her lifetime as a community midwife, and didn't lose a baby in that time. And all moms delivered healthy babies. And through harmful colonial policies, much of that autonomy was stripped away and taken away from communities. So just to highlight some of the news articles here, the one about medical colonialism, midwives sue Hawaii over law regulating Native birth workers. I remember sharing this with Maddie and Sheena when I had come across it. Essentially, there are 6 midwives in Hawaii who had sued the state of Hawaii last year after the government prohibited birth workers without a specific midwifery license from providing maternal health care. So there was a bill that was first passed in 2019. It was the Hawaii Midwifery Licensure Law, which offered an exemption for birth attendants, an umbrella term that included Native Hawaiian midwives who do not have a midwifery license. And the law was only implemented for 3 years. And so when the exemption had expired in July 2023, the Hawaii legislature did not pass a new statute that would allow all birth practitioners to legally offer maternal medicine and care. So there's an example of the recognition or acknowledgement of birth workers and midwives in delivering necessary services to necessary reproductive and maternal services to Indigenous communities. From a cultural perspective, the news clip to the bottom right, health policies need to stop marginalizing Indigenous midwives. So just some context for those who may not know. So midwives are, legally permitted to work in Canada, but when you look closely at the policies, there's still some marginalization of the profession and with respects to how midwives are funded or paid. So we had highlighted in terms of the funding only goes up until the first 6 weeks after birth. And I know I've heard from Maddie and even Sheena that, that can be a hindrance, right? And from an Indigenous perspective of delivering holistic care, it doesn't just stop there, right? It's about providing care across the life course. So navigating sometimes policies, historical policies that were implemented, and unfortunately these policies create path dependencies that the course of reversing these policies end up becoming more problematic and complicated. And they are here to stay. Well, I shouldn't say they're here to stay, but they become a lot more complicated to reverse. And that's where advocacy is really important. So how we designed a community integrated care model. So we formed a community academic partnership in 2022. There was extensive community engagement that had occurred before we had launched or initiated the program. For the academics or researchers in the room, hold on to your seats, don't fall off. We rapidly designed the program and launched it without doing any research to start. So we had no theory of change to begin with. There was no formative research that was done ahead of or that factored into the initial design of the program. We designed a program because there was a need in the community, and the team, Sheena, Maddie, and others had that strong aspiration and vision to want to give back to the communities and start to bridge that gap in reproductive healthcare access. So our Care Lab team had supported with the initial design and launch of the program, and then we started to build in research components or pieces. But the other point I wanted to highlight about rapidly designing the program and launching it without any consideration around an evaluation lens or bringing research or any formative data collection into the design, I think also speaks to how community-based programming and services are offered in Indigenous communities, right? It's not to say there wasn't knowledge. There was immense knowledge. It was the knowledge that Sheena holds, the knowledge that Maddie holds, the knowledge that, the insights that were gleaned from the community engagement. All of that is important information and knowledge that helped us to launch the program, but also helped to demonstrate the importance of this program and the need in the community. Very early on, we prioritized grant development. So that's in part of our community academic partnership. Our Care Lab team supports with grant and fund development for the program. And that includes funding to both provincial, municipal, or federal granting programs. Currently, the research is applying implementation science. So we're drawing on a few implementation science theories and frameworks to support our implementation process and sustainability of the program. So implementation science is helping us ask really important questions about the context and the changing nature of the context and how we address context in our program delivery. It's helping us to ask, really important questions around strategies that we implement to support reach and access of reproductive health services, and also includes Indigenous-led evaluation. We have a fantastic graduate trainee, Elliot Young, in our Care Lab, who has a background and extensive knowledge, experience in Indigenous evaluation. And so he's bringing that work or expertise into supporting the program. And currently, we've been doing quite a bit of retrospective and developmental evaluation. So while we rapidly designed the program and launched it to meet the need in the community, and again, this was implemented at the height of COVID-19, so that also speaks to the need for the program. We've been doing some retrospective evaluation, which is encouraging us to go back to capture a lot of information about what we did, how we did it, what worked and what didn't work. And developmental evaluation is really about building evaluation into the program as an ongoing process, not something that happens at the end or after a 1 year mark or the 2 year mark, but developmental evaluation for us, the data that is being used to support that includes case debrief meeting notes. So the Aunties Within Reach team meets monthly as a team. They case debrief, they review their, or collectively discuss clients that they're serving, or other, or perhaps, challenges or other considerations around the program. So it's having that insights around from those case debrief notes. The team uses an electronic medical record called a Curo, so that helps us in collecting practice-based level data about the clients, what types of services are being offered, any health considerations. So developmental evaluation, as I mentioned, is ongoing, and so every monthly we are regularly collecting data, which is important to help us better understand how the services are being offered, but also allows us in real time to go back and make any changes to strengthen the program or to improve our components. I'll hand it over to Sheena. So Sheena had led the design of our AWR program framework, which in itself is our implementation science framework. It outlines the importance of context, the contextual environment in terms of economic disruptions, the health system context, intersetting factors in terms of social determinants of health, in terms of access to housing, food insecurity, social relationships, etc. but also then goes into our highlighting the aspects of care and services that are offered. So over to you, Sheena.
So when we developed this framework, we really, again, as people that are connected to the land, we wanted to incorporate the land. And the fireweed flower is very important in our region, and it's also the name of our collective. So Ikapesqua is the Cree word to describe fireweed. And to us, the flower in itself represents resiliency. And to us, like these fresh little babies coming into our communities as these big, bright, beautiful flowers. So for us, we wanted to highlight our continuing support, our circle of support. So really rooting them in with their family, their culture, their identity, and their traditions. And you'll see that highlighted kind of in the flower roots, and then that circle of support that's around them. And then in the flowers, it's really of like the implementation of our program and what we support in. So health equity and access, spiritual things such as access to culture and ceremony, emotional support, fostering healthy relationships, sharing parenting circles, physical support, so that midwifery support, lactation support, and all the supportive ways. And then as Stephanie mentioned, you see those external factors, things that can get in the way of having that really strong sense of family, those social supports. So this framework we also have implemented into what we call our circle of care or intake form. So we meet with our clients and we basically have them kind of highlight external factors that are causing a barrier for them. So say it's lack of housing, and we get them to look at inside what are some areas where you're needing more support? So how can we support on the inside, but what are some things that we can do to navigate those barriers that you're facing from these external factors? And then we'll work together with our aunties to come up with a care plan. And then we meet with them every so often to revisit this and to relook at, okay, is this still an external factor for you? No, what is there another one that we need to kind of remove that barrier to? Are there other areas of implementation that you'd like us to walk with you in this journey, and that ways that we can support? So again, bringing in the land, bringing in that really important like circle of support, and having them go by this.
Thanks, Sheena. And I just wanted to highlight, and Sheena talked about this, but I think that's really another novel piece of the program, but being able to take this framework and build it into part of the care, like the intake process with clients, right? Like walking them through as Sheena mentioned, are these external factors that of these external factors, what are you experiencing? So we have designed what we call a circle of care intake form that helps us to capture this information and then helps the AWR team better understand or know how best to support that client. So I love it. Okay. Just quickly, and we highlighted some of this, but just to highlight, what are the integrated components within AWR? We have a multidisciplinary care team of midwives, birth workers, nurse practitioners, Indigenous support workers, traditional practitioner. We incorporate case conferencing. So with respects to connecting and engaging with other sectors within the health and social system, often connecting, doing case conferencing with those other care providers within the system in the spirit of best supporting AWR clients. We have an electronic medical record for client charting. There are monthly team huddles and debriefs. We have a comprehensive outreach model, which currently we're trying to grow and expand in terms of the mobile aspect of that outreach model. That includes in-home visitation for clients during pregnancy and early parenthood, and then system coordination, which is primarily delivered by supported by the Auntie Navigators. Along the way, we've been capturing some improvement aims. And I call these improvement aims because some that, you know, they are areas where we hope to improve, but also address, but can also be barriers. We know from the integrated care literature, one of the things that is often cited as being really important in multidisciplinary or interprofessional care teams is that that team is co-located in the same space or same facility. Currently, the AWR team are not co-located in the same facility, but we're working on finding ways to address that in future funding opportunities to be able to have a dedicated space, clinic space for the entire multidisciplinary team to be there and have one place for clients to access all a range of supports from the birth workers, the auntie navigators, the midwife, and nurse practitioner. You know, we talked about the system being really siloed and disconnected, and recognize that that's not unique to the Wood Buffalo region, but does complicate access to services and supports. So a big part of the work is building relationships, building partnerships, trying to be, you know, have established common ground with other care providers, and build mutual understanding of each other's work. And the auntie navigators on the team, I think, play a really critical role in bridging that connection and those relationships across health and social systems. Some of the AWR providers are often balancing their time working within other parts of the system. So, for example, Lisa, who's the nurse practitioner, also works in a private primary healthcare practice. And so, you know, that may change in the future with additional funding and resources to support more of her time in the AWR program. But I think navigating, working across different systems can also be a constraint. And then I talked about funding for Indigenous midwifery. So funding for midwifery services in Canada is based on reimbursement for specific care during pregnancy, birth, and early postpartum period. That model can complicate matters, I think, for providing midwifery care or Indigenous midwives seeking to provide broader range of sexual and reproductive services. So that's a limitation within the current funding model. And there's been a lot of research that's highlighted this, research that has shown that salaried funded models for midwives improve clinical care and coordination by providing adequate time and space for community relationships, interprofessional collaboration, and client-centered care. Just wanted to highlight again, we're so proud in terms of how far we've come, and AWR is officially an award-winning program. We've recently Quality Council of Alberta website to see our video highlighting the program. Okay, I realized that we're probably coming up to time and wanted to do a temperature check with Erin and Michelle. We did want to ask some questions. I think that maybe in the interest of time, I might skip this because I wanted to talk, and maybe I'll see if we have some time to build in these questions at the end rather. I just wanted to jump in and highlight a little bit about the research. And I just have a few brief slides about that. So we talked about how we formed a research partnership with the Igapasqua Collective, and that research partnership facilitates co-design and co-implementation of the Aunties Within Reach program, supports grant development, capacity development, and knowledge mobilization. We are promoting research that is community-based and participatory, strength-based, resilience-promoting, relational, and acknowledges complexity and system dynamics. So for those who do know me as a policy and systems scholar, I draw on a lot of complexity thinking and systems thinking in much of my work, and I find that to be really useful in the work we're doing with the AWR program in terms of understanding complicated, policy landscapes, the health system as complex adaptive systems. And systems thinking really allows us to kind of zoom out and understand that we can't see things in an isolated way. We need to understand how there are multiple factors or components that are often interrelated and interacting and shaping healthcare experiences and health outcomes for Indigenous peoples. And just some pictures here about our team. So on the far top right is our Care Lab team supporting the AWR program. So shout out to Nicole Orgy, who's our research manager, coordinator. We have Erin, who you've met earlier, facilitator, who's our moderator for the session, and Elliot, Elliot Young, who I also mentioned, who's supporting with evaluation. And some members of the AWR team. I recognize Lisa's missing from this photo, apologies, but that's probably a good 95% of the team right there at the ATC Culture Fest. So the research program, we formed our program is called the Wood Buffalo Healthy Families Program. Our funding comes from CIHR's Indigenous Healthy Life Trajectory Initiative and the National Women's Health Research Initiative. We're also grateful for the partnership funding that we receive from WCHRI and implementation science support from the Apps for You Learning Health System team. Denise is on the call. Denise will talk more about this, but wearing my hat with the LHS team, I see that as an opportunity to bring in support. And one of our team members, Candice Ramjan, who has brilliant expertise in graphic knowledge mobilization, has actually joined in on a workshop that we delivered, Sheena and I, last week at the Integrated Care Conference, and is graphically illustrating a lot of the discussions we had at that workshop. So it's really great to build in strengths and expertise from so many to make this work possible. Our work is focused on restoring Indigenous healthy family systems. It's grounded in Indigenous knowledge, culture, and experiences across the lifespan, and aims to improve the health and well-being of Indigenous parents and parents-to-be from preconception into pregnancy and postpartum. On this slide here is our one-page information sheet that we're often handing out at community events, workshops, or meetings to share about our program. And the purpose of the Wood Buffalo Healthy Families program is to gather Indigenous knowledge on strengthening healthy families, to learn about the health and the well-being of Indigenous parents, to work with the community-based team in Wood Buffalo to identify culturally appropriate measures for parental, social, and emotional well-being and child well-being and development. This will be led by Erin, who's our PhD trainee. And using knowledge that is required to allow us, or feeding that knowledge back in to refine our AWR program and implementation strategies. Equity is very centered in all of our work, which for us raises a number of questions and considerations about how we build equity into our research and program delivery. So it's really about asking questions around whose voices are being privileged, whose knowledge is included, who's on your research team, which methods are we using, how are we measuring our outcomes, which social determinants are we measuring, and how are we examining structural racism, discrimination, or other forms of structural violence. We do have a community advisory committee that guides the implementation and sustainability of our community-driven strategies in the region, guides all aspects of the research approach, and also is a space to facilitate relationship building, learning, and knowledge sharing. What's really important to the program, and many of my team members will hear me say this over and over again, because it really is something that I care deeply about, but it's about aspiring young people in the communities who want to take up and do this work. So capacity building and mentorship is a core component of our Healthy Families program. If you haven't already met Kaylin, meet Kaylin. Kaylin, I think, is on this call. She's our fantastic community engagement and project coordinator. Graphic extraordinaire, develops all of our materials and is just a lovely person. So we are grateful to have her on the team, and she supports a lot on the ground in terms of community engagement and data collection. And I'm going to just highlight this one framework as an example of a health equity implementation framework that we've been using. So some of our sharing circles and interviews, we've been more recently using the health equity implementation framework to guide the sort of questions we ask. So the Health Equity Implementation Framework explores 3 health equity domains, including cultural relevance, clinical encounter, and social context, to explore healthcare experiences for clients, and access to care, as well as social and cultural needs, and their access to health and social services. And it helps us to really hone in on understanding the context in terms of the outer context as well as inner context in terms of, the community context itself. So that's where we're asking questions around barriers to access and other geographical constraints that may pose challenges in accessing reproductive services. And where we're going. So I promise I'm at the end. Where we're going, again, a shout out to Candice Ramjan from our ABSPOR U-Learning Health System team, who took our proposal that was submitted to CIHR's National Women's Health Research Initiative and has helped us map out a 3-year implementation plan for us. I mentioned earlier that our long-term goal is to really expand our outreach model, our outreach mobile program, which includes providing multidisciplinary reproductive health services in the communities. And this grant is helping us map out that process for us, and we're using participatory planning, the Health Equity Implementation Framework, to guide that process for us. And lastly, thinking about sustainment. Sustainability for me, I think, highlights a few key points, and that's where I want to end off today. 1, it demands courageous leadership. Secondly, it's about continuously studying implementation dynamics, contexts, relationships, policy changes. It's also about taking hold of opportunities when they present themselves. It's about embracing complexity. And most importantly, it's about being relational. Thank you for listening to our presentation.
Thank you, Sheena and Stephanie, for your excellent presentation. I might be a little bit biased, but and your beautiful work. So now we'll open it up to questions. If anyone has a question, I'd ask you just to use the raise your hand feature, and I'll try to get everybody in order. Or if you're a little bit shy, please just enter your question in the chat and I can read it out. Thank you.
Should I ask the questions we had? Okay, hold on, what were those questions now?
Sure.
Yeah, there's a hand. Yeah, Saya, please go ahead.
Okay, so this is amazing work that you're doing. So now I'm going to put on I work in a provincial health system hat and ask, have you thought about or even dabbled in the idea of having conversations outside of the Wood Buffalo area with other communities or with stakeholders who work with other communities and support them about this work and having something so successful and important spread beyond your excellent boundaries as geographic boundaries that you have right now?
Yeah, great question. Sheena, did you want to take that one on?
I think that's always our goal, is to share what we're doing and what's working and what's not working with other communities, and for us to kind of be the pilot, so to speak, for other people to develop this in their own communities. We love sharing about what we're doing and how other communities can do the same. We have met with the Métis Nation of Alberta, who's really interested in bringing on aunties as kind of their their Bill C-92, like their Child and Family Services model, like their new model. So having conversations with that, what that looks like has been interesting. And even just nations themselves wanting to implement like anti-resource navigators to really support families in a way that's holistic and culturally relevant, I think has always been kind of on our mind, and always eager to share and to teach basically about what's working and what's not working.
We talked about having the Aunties Roadshow to just connect with other programs. And Sheena and Maddie in particular have done quite a bit of that. I know they were in Toronto not too long ago, visiting the birth center there. They've been connecting and working with NICM, the National Association of Indigenous Midwives. I probably did say that correct. Put me on the spot with acronyms and I'm terrible. But so to your point, say absolutely. And I think a lot of that needs to be driven and led by the team, and I'm happy to support as I can. You know, and they have joined our Care Lab team. We come often together at conferences to share our program, and so that's also been a fantastic way to share about the program and connect with others.
Thanks so much.
Yeah, I know we've got 3 minutes left. You know, I swear I only had 37 slides, but you know, you slow down and you take the time to share story. Just like we filled that hour and a half really quickly.
Yeah, so it's up to you, Stephanie, if you want to ask those questions, or we could wrap it up.
I'm also mindful there's just three minutes. So for those in the room, we did build in some questions as a way of just getting conversation going. I just don't know if the interest of time that we might not have that time to get into it. But yeah, I mean, if anyone else has any comments, thoughts, feedback, we'd love to hear from you.
Definitely reach out to Stephanie and Sheena if you have any questions, comments, concerns. We really do want you to provide your feedback and to engage with the presenters today. Rhonda, please do go ahead.
Oh, I think we may have lost
We
Rhonda.
dropped off. Oh, still there. Put her hand down, I think.
Yeah.
Okay, well, that kind of brings us to the end of our time today. So thank you again, Stephanie and Sheena, for presenting. Thank you for WCHRI for organizing this event. And yeah, until next time, reach out to Stephanie or Sheena if you have any further questions. Thanks for coming.
Thank you. Thanks, Erin, for facilitating or for moderating. And thanks to everyone who joined and hearing about our program. And thanks especially to Sheena.
Thanks for having me.
Thank you.